My name is Fozan Khan. I'm currently working in Swat, but previously I worked for almost 14 years in the UK, and then for 3 years at Rahman Medical Institute, Peshawar, where we established the first dedicated stroke unit of KPK. So the talk which has been kindly assigned to me by the Pakistan Stroke Society is about the management of spontaneous subarachnoid hemorrhage. So I'm going to focus on non-traumatic subarachnoid hemorrhage during my talk. So I'm going to talk a bit about epidemiology, clinical features, the relevant investigations, treatment, preventing brain injury, some other complications, and the rehab aspects of the subarachnoid hemorrhage. So this is the typical CT scan of an extensive subarachnoid hemorrhage. So subarachnoid hemorrhage is uncommon. It accounts for about 2 to 7% of all strokes. But importantly, the majority of patients with subarachnoid hemorrhage are from the younger population. So it means more mobility and more mortality in younger mean age. The incidence is about 6 per 100,000 in developed countries. Unfortunately, we lack statistics in our country. So it's difficult to say how many patients per 100,000 of the population we see coming with spontaneous subarachnoid bleed. For some unknown reason, there is female predominance of having subarachnoid hemorrhage. And the mortality calculated in North America is about 4.4%, which is high. So it's going to be quite higher in our setup. So the risk factors of subarachnoid hemorrhage include smoking, which is very, very important risk factor, uncontrolled hypertension, and excessive alcohol intake. And we discuss about female gender. So the important clinical features of subarachnoid hemorrhage, the typical scenario is sudden. The word sudden is very important here, onset of severe headache, which usually patients report the worst headache in their life. Some patients, actually the majority of patients may present with thunderclap headache, but it's not the rule that every patient with subarachnoid hemorrhage will present with thunderclap type headache. Usually patients tend to have neck pain and stiffness. So we talked about some important risk factor epidemiology, and I was talking about the clinical features. So the clinical features, the most important aspect of patients presenting with subarachnoid hemorrhage is the sudden onset. Because headache presentation is quite common to the emergency department, but when we talk about subarachnoid hemorrhage, it is usually of sudden onset. Usually patients report that it is the worst headache in their life. Majority of patients may have symptoms of a thunderclap headache, but it's not the rule. Neck pain and stiffness is common. Altered GCs is quite common. Some patients present with cranial nerve palsy, hemiparesis, cerebellar signs. Some may have even papilledema if they have developed raised ICP. And headache may be the primary and sometimes the sole symptom in 70% of the patients without other neurological deficit. So I'm going to talk about Ottawa SAH rule, which has got a very, very high sensitivity. So basically, if you are seeing a patient in emergency department, and if you would like to know whether you need to investigate further in the context of subarachnoid hemorrhage, then it's kind of screening tool with a very, very high sensitivity, but with very low specificity. So it applies to alert patients who are aged more than 15 years with new severe non-traumatic headache reaching maximum intensity within an hour. It is not for patients with new neurological deficit, previous aneurysms, subarachnoid bleed, brain tumors, history of similar headaches more than 3 episodes over 6 months. So investigate further if one or more of the following is present. Number one, symptoms of neck pain or stiffness, age 40 or above, witness loss of unconsciousness, onset during exertion, thunderclap headache, and limited neck flexion. Then you have to proceed to the investigations of subarachnoid hemorrhage. And the first line investigation by default is a non-contrast CT head. So I'm going to talk briefly about CT brain. It is the first diagnostic test. It has got a very high sensitivity, especially if the CT is done on a third generation or higher generation machine within 6 hours of headache. In a neurologically intact patient and interpreted as a normal by neuroradiologists, then subarachnoid hemorrhage is almost excluded. There is modified Fisher grading of subarachnoid hemorrhage on CT brain. So it has been modified by Klassen and co-workers. So the grade 0 is if the patient has got no bleed. One is minimal subarachnoid hemorrhage without intraventricular bleed. Number 2 is minimal SAH with intraventricular extension. The third rate which they use is thick subarachnoid hemorrhage without intraventricular extension, and 4 is thick SAH with intraventricular extension. Can anyone guess which grading it will come, this CT brain? Any idea from the audience? Can anyone guess? Okay, so it will be grade 4. So next investigation is doing a lumbar puncture and testing CSF for xanthochromia. So it is a traditional step if the CT is not diagnostic. Most sensitive within 12 hours, most sensitive if it is done after 12 hours of symptom onset. RBCs are not uncommon if the CSF tap is traumatic. Usually xanthochromia is done. So xanthochromia is checked by visual method and by spectrophotometry. So of course the spectrophotometry, which actually checks for the degradation products of bilirubin is more sensitive. And the most important aspect when you send the CSF for xanthochromia is to prevent it from getting exposure to the light. Because if the sample is exposed to the light, then the accurate lab interpretation is compromised. So this is a picture showing a sample on the left-hand side showing xanthochromia, and on the right-hand side, it is normal. So the other investigations which are to determine the etiology of subarachnoid hemorrhage is the first line is CT angiogram. So the meta-analysis of 8 studies showed that it has got sensitivity of 97% and a specificity of 91% for detecting an intracranial aneurysm. But the rule is that CTA machine, the machine on which CT is done, must be of high quality. So here you can see the left MC aneurysm. So the gold standard is DSA, digital subtraction catheter angiogram, but it is an invasive procedure, and overall it has got 1% overall incidence of neurological deficit. MRI remains inferior to both DSA and CTA. It has got a sensitivity of 95% and less specific. Nowadays, if the MRI is done on 3 Tesla or a 3 Tesla machine, then there is a technique which shows aneurysmal wall enhancement, and it is a good independent indicator of aneurysm rupture in the future. So now coming to the treatment of subarachnoid hemorrhage, any emergency treatment starts with ABCD principle. So A is for airway. So if the airway is not secure, the first principle is to secure the airway. The B is of course, breathing. So if the patient needs supplemental oxygen, then you provide it. C is the circulation, which is to control the heart rate, to treat any extensive bradycardia or tachycardia, and to maintain the blood pressure, and D is for the disability. And also the treatment includes preventing hypoxia and also to avoid hyperoxia, because it's quite common practice in emergency departments to give everyone oxygen. So oxygen is basically a drug per se. So it has to be prescribed, it has to be properly planned that who should be receiving oxygen. So if someone enters the emergency department, then by default, he or she should not be offered oxygen therapy, because hyperoxia can also have detrimental side effects. Okay, so the factors which are associated with rebleeding in subarachnoid hemorrhage are high blood pressure, the worst neurological grade on presentation, intraventricular extension or intracerebral hemorrhage, large aneurysm, pre-existing hypertension, posterior circulation aneurysm, and acute hydrocephalus. So we must treat the acute hypertension, and if we reduce the blood pressure less than 140, then it can also result in increased risk of rebleeding. So typically the blood pressure is maintained between 140 and 160 and not lowered significantly below 140 millimeter of mercury. Aneurysm repair, it's a vast topic, so I can't go into the depths of that. It basically is the this subspecialty or discipline of neurointerventionalist and neurosurgeons. But the options are, of course, endovascular repair and surgical clipping. The ICET trial, the patients with ruptured intracranial aneurysm for which endovascular coiling and neurological clipping are therapeutic options, the outcome in terms of survival free of disability at 1 year is significantly better with endovascular coiling. So basically, the trial was more in favor of endovascular procedure rather than neurosurgical intervention. So how to prevent early brain injury in the context of subarachnoid? So you prevent raised ICP. So different methods can be used, EVD, for example, in neurointensive care setup. Glyburide, basically, which is a drug used to treat patients with diabetes, is an emerging promising drug. It reduces inflammation and vasogenic edema. However, it's still used on trial basis. So the evidence is emerging for glyburide in preventing early brain injury in SAH. In preventing delayed cerebral ischemia, there are rescue therapies which can be offered in highly skilled centers. It can be induced hypertension, though the evidence is of low quality. Where the facility is available, which is, I think, extremely rare in our setup, balloon angioplasty can be offered, and vasodilator infusions can be also offered to prevent delayed cerebral ischemia. Now coming to something more practical, which all of us use in our day-to-day practices about nimodipine. See, if you talk about the trials, so that the good evidence, the good quality evidence goes only in favor of nimodipine and endovascular intervention. So endovascular intervention, as we know, even in countries like UK, is not readily available everywhere. And in Pakistan, very few people can offer it. But nimodipine is available everywhere, even in far-flung areas of Pakistan. So we should know that nimodipine should be started as early as possible or within 96 hours of diagnosis of subarachnoid hemorrhage. It is available in 30 milligram dose, so we should know about the correct dosing as well. It has to be given at least 1 hour before or 2 hours after meals. And the adult recommended dose for adults is 60 milligram, which will be 2 of 30 milligram tablets every 4 hours. And it is for 21 consecutive days. Now, talking about some other neurological complications associated with subarachnoid hemorrhage. So there is no consensus about the use of prophylactic anticonvulsants. Phenytoin definitely is associated with unfavorable outcomes. Hydrocephalus may complicate subarachnoid hemorrhage in both the short and long term. If GCS is decreased, an EVD or occasionally a permanent shunt is required. Just most of us know that subarachnoid hemorrhage can lead to ECG changes, and they are quite common. And about 40 to 70% of patients presenting with subarachnoid hemorrhage can have ECG changes. They can typically include, ST elevation that can mimic a heart attack, changes in QT intervals, Q waves, and cardiac dysrhythmias. Now, a bit about the rehab in the context of subarachnoid hemorrhage. So patients presenting with subarachnoid hemorrhage, every patient should have specific rehab goals, because every patient with subarachnoid hemorrhage may not have similar neurological deficits or functional disability. But in general principle, the rehab aspects of the subarachnoid hemorrhage must include preventing DVT. So intermittent pneumatic compression devices must be used, because we can't give them Clexane in the context of subarachnoid hemorrhage. Air mattress must be provided. So Ravi talked about the stroke unit. So air mattress is a very vital component of the stroke unit beds. Patients must receive regular turns. In stroke unit also, each bed must have IPC provision, which is the intermittent pneumatic compression devices, cost around 50 to 60,000 rupees. Optimal nutrition must be provided, and it must be MDT approach. It must include speech therapists, physiotherapists, nursing care, occupational and psychological therapies. Early mobilization is reasonable, and most guidelines recommend early mobilization, but there is no good evidence for this intervention. Functional outcomes. So it is important to know that patients recovering from subarachnoid hemorrhage are less likely to have focal neurological deficit, but they usually present with persisting functional outcome challenges, such as executive dysfunction, short-term memory loss. They can become very impulsive. They may have poor concentration, anxiety, depression, and fatigue. So a psychotherapy input and certain medications are important as part of their rehab. So in conclusion, neuroimaging has improved, which has simplified the diagnosis of subarachnoid hemorrhage. Early diagnosis and treatment has improved outcomes. So now patients are, surviving after subarachnoid hemorrhage, surviving better and surviving more. Nimodipine and intravascular aneurysm repair are the only high-level evidence-based treatments. Since subarachnoid hemorrhage is uncommon, multi-center trials are needed. So I conclude my presentation here. If there are any questions, then I'm happy to take. Thank you.